I'm one of 4 interventional radiologists in our group. We have 10 radiologists. Interventional radiologist is a subspecialty, so we're all radiologists in basic training, and then interventional it's a very simple definition. We're intervening, meaning we're acting on the patient using the tools of radiology. So depending on your need, whether it's I don't know if anybody in here has a friend or a relative who has had complications secondary to diabetes or hypertension where their kidneys have failed and they need dialysis. And dialysis is medicine's way of taking over for the kidney function. They will have what we call surgical access to their veins and arteries. And we provide some of that access, and we provide maintenance of that access. Another procedure we do is placing ports for chemotherapy or sickle cell patients who need what we call venous access. Any patient who needs to receive medications on a regular basis, who's getting tired of the simple IVs that you may have had in doctor's offices or small procedures or even major procedures you may have had. Any patient who needs this venous access on a regular basis, whether it's on an organized basis, meaning every month, or unorganized, but they would know several times a year they need that access. If there's a mass somewhere in the body, one of our jobs is to get some of that tissue for a diagnosis. The advantage that we have with technology today is to be minimally invasive, meaning most areas of the body we can access with a needle, passing through even vital organs with usually no injury to them or no permanent injury, and getting a diagnosis where 10, 15, 20, and even further back, you'd have to have a major operation just to get access. So they would usually try to remove whatever it was then, and sometimes these are in very tricky locations. And there are sometimes when you have a benign tumor like fibroids that would not have to be removed, so you would not have to have a risky surgery if we can just get a piece of that. If anybody's ever had thyroid problems, we do biopsy for those. That's where just using ultrasound to see where the portion of the thyroid gland, which is a gland that's in your throat or in your neck, we can do that, and that's an outpatient procedure. It takes very little time, and you end up with a Band-Aid, and in a couple days you find out if it's something you need to even worry about. There's a long list, and my hope would be that you'd never need me. Doctors that refer to us often say, well, I haven't sent anybody to you in a while, and I said, well, that's bad for me. I don't get to practice my art, but good for the patient that they weren't sick enough to need me. Like I said, there are 4 interventional radiologists in our group. There's Dr. Kelvin Belcher, who's our section chief, who's head of IR at the 2 hospitals. Dr. Melissa Seeley Morgan. I believe all of our names are somewhere in the paperwork you've received tonight. By her name you can tell she's a female physician, so should you like to have this procedure and need to have this procedure done and prefer to have a female physician, that we do have a physician that would fit that bill very well. And Dr. Ajay Joshi, who is our most recent addition, who trained in Chicago, and myself. So there are 4 to choose from, and towards the end of the procedure I'll remind you that after you had this information, and if you are symptomatic, meaning you have symptoms because of your fibroids, then that would be when you would want to make an appointment and come talk to us about the procedure, so you find out about that procedure. And I'll tell you that when you do speak with Crystal, you would need to just make 3 choices: where, when, and who. Who would be one of the 4 of us. We don't get extra points for trying to recruit more patients on our days. We're here for your convenience and preference. Where, there are 2 hospitals, DeKalb, the main campus and on North Decatur Road, and Hillendale, which is right across the street here. We do the procedure on a regular basis at both hospitals, so the staff and supporting physicians are well versed in it. I know this is a 100-bed hospital compared to over a 300-bed hospital on the North Decatur campus. Bigger is not always better, it's just different, and different here meaning only in location. And then when, you would have to, when you do speak with Crystal, if you choose to have this done, You would have a calendar, your own calendar, your work calendar, whether you're a stay-at-home mom with your own kids, maybe neighborhood kids, grandchildren, nieces and nephews that you need to take care of, or have birthday parties coming up. All those activities, you need to find a slot in your schedule where that would fit nicely for you to have the procedure and have enough time to recover. So your responsibilities would be next to nothing during that recovery time to allow you a no-pressure situation. I think they're still working on the computer trying to get that going, so I'm going to just start. Probably the easiest way is first start with what fibroids are, and they are benign growths. You will see in some of the literature, most of it, they are tumors. And tumors are either cancerous or benign. Benign is non-cancerous, not something you have to worry about. But obviously, and maybe everybody in the room that's come to listen to this tonight is already having symptoms or have siblings, older, younger sisters, mothers, grandmothers, aunts who have had symptoms and needed treatment. The traditional way, and it's still done, is a hysterectomy. That is major surgery, that is one of the options, but what you came here tonight is to learn about one of the other options. And I'll tell you right now that you have 4 options. 2 are surgical, the hysterectomy, complete removal. Second is a myomectomy, which is also called a partial hysterectomy, where the surgeon, your OBGYN, would remove part of the uterus, and that would be the fibroids that are hopefully the ones causing you the problems. They're the larger ones. And unfortunate for patients, it's not always just that you have one that's causing a problem. Some women have dozens of various sizes, and their locations would determine whether they're going to cause you a problem or not. Some of them cause problems like heavy bleeding during your menses, sometimes spotting in between menses. Other times it's pain, sometimes throughout your cycle, sometimes between cycles. Most women have maybe some pain just throughout the month, and it just gets worse around their menses. Another one would just be what we call mass symptoms, because you have a mass, a benign mass, but it's taking up space where normally your body would not expect it. And in your pelvis, you can think about your pelvis as a bony bowl. There's only so much room in that bowl. Think about a bowl you may have on your kitchen table filled with fruit. It's not an endless bowl that you can put all the fruit that you want to, all the apples and oranges. Eventually they're going to start coming over the edge and over the top. These fibroids are coming from your uterus, which your uterus will not come over the top, will not move out because that's where it's supposed to be. So it starts pushing on the other organs and causing problems. Some of those problems are frequent urination, feeling like you need to urinate every 1 to 2 hours maybe, when 10 years ago you knew you could maybe even last all day. Constipation, difficulty with bowel movements, or even just pain. There are several structures in the pelvis that if you push on them, they're going to hurt. And the only way it can tell you that there's a problem in your body is causing pain to draw your attention to it. So any one of these symptoms can be caused, or all of them can be caused by the fibroids. When you come talk to us for a one-on-one consult, you have an MRI done that same day, and that allows us to see everything in the pelvis and make sure, one, that you probably already know you have fibroids. We're just getting a better picture of those, seeing the number, seeing where they are in the uterus. You'll see some pictures probably in your some of the pamphlets where it has a diagram or even a cartoon version of the uterus, and it will say different kinds of fibroids. It's the same tissue. So for a doctor who's a pathologist who looks under a microscope, if they were to remove the uterus and say, well, you have some growing on the outside and some on the inside, when you're looking under a microscope, it's all the same type of tissue. It's where they're growing, and that can affect the symptoms. The MRI does allow us to determine whether you're a safe candidate for those. There are some fibroids that they're growing literally just one connecting piece called a stalk on the outside of the uterus or on the inside where the baby would grow, but it's connected to the uterus only by a thin band of tissue. Sometimes it's a very thick band of tissue, and that would be okay. But it's when it's a thin band, it's not safe to do this procedure, that we would probably want to do a combined procedure where the OBGYN surgeon would, on your admission to the hospital, have you in the operating room and remove that one fibroid or 2 fibroids that are in that category, where they're growing on the thin band, And then the next day, before you go home, you come down to our suite and we do our procedure. So if we tell you you're not a safe candidate, at that time we're not saying you can't have the procedure. We would just want to work with your OBGYN to try to coordinate treatment. After the MRI on the day of your consult, you would be then coming to see one of the four of us and sit down. We'd go over the pictures with you, show everything there. MRI has the advantage of being able to look at your body in any plane, meaning any slice that we would want. Not all modalities or types of imaging have that. We use the MRI because we can do that. It's safe. It does not involve what we call ionizing radiation. You hear stories, you may remember names like 3 Mile Island or Chernobyl. The type of radiation, one of the types is dangerous, is ionizing radiation. That's why when you go to get an x-ray, you're the only person in the room when that machine turns on. MRI does not have that. So you don't have to worry and say, well, I don't want to have unnecessary radiation. This is not the risky type of radiation. You do receive contrast during it, so you will have one of the simple IVs put in and you'll get that medicine, and we'll show you the benefits of having that when we show you the pictures. Like I said, after the MRI you'll come to us and we'll show you the pictures. We'll go over the 4 options. I mentioned 2 already, which are the surgical ones. That's a hysterectomy, and that's the surgical removal of the uterus. This will not grow back. This is permanent. And this is the only procedure, actually, that is absolute. It will remove any symptoms caused by the fibroids because it's removing the organ that they're growing in. The remaining ones, a partial myomectomy or the myomectomy, that one is just going after the larger, usually more offending fibroids. It does not remove all of them, and some can continue to grow and then cause problems later. That's one of the downsides of that. Another option you have is to do nothing. You're never forced into having a medical procedure. But if you're already here tonight, you've probably gone past that point. You're tired of doing nothing. Jennifer used the term watchful waiter. Some women have been told they have fibroids and they've been found on their regular GYN exam, and the doctor's telling you have them just so you know. You may have asked, you know, my older sister has them. She's having some problems. My mom had them. She had a hysterectomy 20 years ago. It's information for you to have. And then if you do start to develop symptoms, then you know what that's potentially not a cancer that's causing the problem, not anything else, but it's something that we can treat. The last one of those 4 is what we do. It's a minimally invasive procedure. Again, we make a small incision. It's about that long. It's about 5 millimeters. It's about less than half the width of your pinky. It's about the width of your pinky nail. That's right at the groin on one side, right where your thigh meets your abdomen, where the fold in skin. If you were to raise your thigh and see where your skin fold is, that's where the incision's made. And we make our puncture there. We get into the arterial system, which is one of 2 vascular systems or blood systems in your body. Our goal is to first gain the access safely, and then using our x-ray equipment, we guide our catheters, which are very small tubes, into the uterine arteries. Now you have 2 of those. There's one on each side, and anatomists are nice to us and give us very simple names to remember which ones they are. So the uterine artery. When our catheter is in the safe place, we will inject a little dye to make sure it's in the right place, make sure it's in a safe place to finish the procedure. And at that point, we start releasing our beads, which I will pass this around. It's in a syringe like this. This is not one that we use. Obviously, this is one we bring to presentations and our consults. If you give it a swirl and look at it, you'll realize there's several thousand very small things floating around in there. You can't really focus your eyes on any one of those because they're so small, but you'll see them moving. It's like holding a small pile of sand in your hand. It's really hard to focus on one grain, especially if it's moving. So we'll pass this around. You'll be able to see that. That's what we use. Now our catheter is sitting inside an artery, and blood is constantly passing by it, and that's normal because you're circulating blood throughout your body. When we shoot our first little puff of dye out, and that's just the dye to make sure it's in a safe location, that dye is picked up by the blood passing by, and it passes down the rest of what we call the arterial tree, all the blood, all the organs that are fed downstream from that. Picture throwing a bucket of tennis balls in a river. Well, those tennis balls are just going to float down that river. The river decides where they're going at that point. Tennis balls do not have a choice. These beads are just like those. They will travel down until they reach a branch point, and the arteries will continue to branch, and each branch is a little bit smaller. When they reach a branch that's too small for them to go any further, they will stop, they will get stuck there. There will be no further blood flow beyond that point in that small branch. Now we give tens of thousands of those, a couple of those syringes usually. And what that does is it blocks the blood flow to that part of the uterus where the fibroids are, and it's blocking the blood flow to the entire uterus that's fed by those two arteries. Now fibroids need two things to grow, just like any person needs. You need nutrients, oxygen and other nutrients that the blood brings. The other thing it needs is a signal to grow. It needs to be told to grow, and that signal is your normal level of hormones. And we were talking about, do we want to pass that around?
Would you rather pass it?
Yeah, you can pass it. She's going to pass around something that you'll see at your consult. This has that picture where the fibroids are growing in different locations. The fibroids, like I said, need two things to grow. It's their blood supply, giving them all the nutrients that they need, and then a signal, which is the hormones. Now, your hormone levels are not abnormal. They're circulating, and one of the reasons that you may find that your symptoms get worse around your menses is because around your period, your hormone levels go up and down very rapidly. So that fibroids are getting very strong signals once a month to change. Now, they don't suddenly grow and then get smaller, but they're being stimulated. And when they're getting stimulated, that can exacerbate or make worse your symptoms that you may be lucky enough not to have between periods, but a lot of women have a very low level of symptoms between periods and just have a lot more pain or a lot more bleeding during their period. Now when we release these beads, and we do it on both sides, like I said, you have a uterine artery on each side, but we do one puncture, and we can guide our catheter through that one puncture to both sides. Now, you may ask, well, what happens if you cut off the blood supply to the uterus? Well, if you took it all, it would not be a good thing, because the uterus is a normal organ. If you're having this procedure, you probably want to keep your uterus. But the uterus does have a backup blood supply. Most organs in the body have large arteries and small arteries that feed them. We're affecting the two large arteries. So the uterus has a backup blood supply. And it does fairly well during the short period that we're blocking the large arteries. And it takes a very short time for those backup arteries to increase their blood flow and start supplying the normal amount of blood flow to the uterus. The fibroids are not normal tissue. You were not born with them. They don't have a backup blood supply. So when we knock out a majority of their blood supply, if not all of it, they don't fare well, but we don't care much for them, so we don't have too much concern for those. And it's that knocking out of their nutrient supply that causes them to no longer grow and actually start to get smaller. They're not metabolically active, so that response, and when I use that term metabolically active, they're not growing, they're not being stimulated anymore, and it's that stimulation that can cause increase in symptoms around your period. Now, they didn't grow in a week, they didn't grow in 1 month, they grew over usually several years, so it does take several months for them to get smaller. And it's usually during the first 6 months during the procedure that every period after the procedure you're noticing a decrease in your symptoms. So each month after your period you'd say, well, we would hope that you would be able to say to yourself, you know what, that was better. That was a much lighter period, less pain. You'd be able to, if you do use a lot of medications to get through your period, hopefully you'll be able to say to yourself, you know what, I used half as much. Some women do miss work on a regular basis because of this, and they'll start realizing they don't have to miss that work. We have treated patients that it's been so bad for them, their bleeding is so bad, they've had repeated transfusions. They've ended up having so much bleeding that their body cannot replace the blood fast enough through its normal development that they will pass out sometimes or just feel so weak that they need to go to the hospital and get a transfusion. That is an extreme. Most women do not suffer from that. But these women do very well. The symptoms that are best treated by this are heavy bleeding and the pain. The mass symptoms about the fibroids taking up space in your pelvis that I mentioned, Those are treated well also. But I need to tell you that, and usually most women are complaining about the pain and the bleeding. It's not like when they were 15. We would hope that several months after this procedure, we'd be able to get you much closer to your teenage years, to where you weren't having to take a lot of medication. You were not embarrassed or concerned about any activities that might fall around the time of your period. You wouldn't be missing work, and you wouldn't be headed to the hospital for transfusions. After your consult, we will be going over a lot of the same material and discussing the procedure as well as your options, because that's our job, to tell you what you, show you the pictures, show you what you have, and give you all the options. The risks, the benefits, and the alternatives. The alternatives are the other three things, the 2 surgical procedures, and then the watchful waiting, would be doing nothing. Your GYN surgeons would be able to tell you more specifically about the procedure, the surgical procedures, but those are surgical procedures. Some of them are referred to as what we call open procedures, where you have a large incision. Others are done laparoscopically. Some people may know people who had their gallbladders removed in the last 20 years, where they say, well, they just made these little holes, and I woke up with 3 or 4 of these little holes in my abdomen or your belly. That's where they make a small hole, and they put what we call a port or a small tube through, and one of those will have a camera, and the others will be for instruments. Now, sometimes your surgery can be done that way, but again, going beyond that would probably be something for your GYN surgeon to discuss. Our procedure is minimally invasive. Like I said, the biggest incision you're going to have is the width of your pinky nail. What you could hope for, most women are back to their normal level of activities within 7 days. I have had patients who were back to normal in 3 days. Some women take a little longer. Most women are just under 7 days. And you come in the morning of your procedure. You'll check into the hospital. You get a nice little hospital gown, which most people have seen on TV. They're just as nice in person. You'll come down to our procedure suite. You'll see us again because you've already seen us. You'll have the procedure done always in the morning. You're almost always back up in your room by 12 noon. Now, with the medications you'll get during the procedure, you won't be looking at the clock. You'll be quite sedate but conscious. And we tell you when you feel comfortable eating and drinking, getting up and walking around, then we urge you to do so. You stay in the hospital overnight. That is for what we call pain management. The pain medicines you'll be getting will be given through the IV, the small tube that's in your vein in your arm. Some people are nauseous after this procedure. So if you're nauseous and you can't tolerate taking a pill, having a nice bottle of pills is not going to do you any good. So we give you those pain medicines through an IV. The next morning, we come by, we check on you, we see that you're okay. We tell you what to expect or remind you what to expect. Some of that I've discussed here tonight. The entire process will be covered during the consultation. We remind you and give you paperwork that states it once again what to expect in the coming months. About 6 months after your procedure, we're going to have you back in the hospital or in our outpatient imaging center to get a follow-up MRI. And then after that MRI, you'll get a phone call from us to tell you, well, we've seen significant improvement on the pictures. That usually goes along with your improvement that you've already been well aware of for months. And we make sure again, 6 months out, that you're doing well, you have no complaints, and no other concerns. Some of the other procedures that we're still trying. Okay. The endometrial ablation, that's where the lining inside the uterus is ablated or burned, and it destroys that. And it's that lining that's responsible for creating the bleeding that you have every month. Now, if the surgeon burns that or basically takes it out of the picture, you're not going to have the bleeding. If pain is a symptom, that doesn't treat the pain. And one thing everybody needs to remember, when we're dealing with the uterus, all therapies can impact your ability to become pregnant or maintain a pregnancy. Fibroids can impact that ability as well. Some of the women that we see are coming to have this done because they haven't been able to get pregnant. Their GYNs have run every other test that needed to be checked. Their hormone levels are okay. Their husbands are okay, or boyfriends are okay. So the mechanics are there, but the fibroids are creating a problem. But endometrial ablation, burning the lining of the endometrium or the inside of the uterus, you will not be able to have children after that. Obviously, if you have a hysterectomy, you will not be able to have children after that. A myomectomy or partial removal, that can affect your ability to become pregnant, but one of the things that the surgeon keeps in mind during the procedure is trying to maintain the uterus and its viability or its ability to function. The goal would be to remove the fibroids that are causing the problems, whether it's preventing you from becoming pregnant or maintaining the pregnancy or the other symptoms. The goal of that is to maintain a uterus. That is also one of our goals. Now, we're not removing anything. The fibroids, once we take away their blood supply, start to shrink. And it's their metabolic activity, the fact that they were living, viable tissue or happy tissue growing, and their size is usually what's causing the problem for you. We're preventing both of those. Now, having this procedure can affect your ability to become pregnant and maintain a pregnancy, but there have been no studies to look just at that because it's not really ethical to do that. A woman's ability to become pregnant and bear a child is something that's held sacred by most people. So if we were to test women and test their ability to have that ability, then it's not going to be well received, and it's just plain unethical. What we call retrospective studies, when we look at the tens of thousands of women who have had the procedure, there is plenty of evidence that shows most women can become pregnant and maintain a pregnancy after this procedure. There are some women who had normal pregnancies before and after the procedure who tried again but could not. We have to assume that their procedure did affect that, but most women do just fine with having a pregnancy after this procedure. But we do need to tell you that we cannot give you a percentage chance. We can't say it's a 1 in 10 chance that you may not be able to have any more children or children after this. There's a lot of information you need to take into account before you have any surgical procedure or non-surgical procedure, and that is one of the important ones. Now, a lot of women have come into the office, and I've sat down with them and said, well, I had my tubes tied. Well, then they're done with that. They don't have to worry about that. Another procedure is called focused ultrasound waves, and that's done in the MRI. That is approved by the FDA. It's not funded by Medicare or private insurances in all states, and last time I checked, Georgia was not one of those states that is funded. It does have limitations. It has benefits. You do have an IV, but that's the only thing that goes inside your body during that examination. You've probably all had ultrasounds, whether it was for pregnancies or just to look at different parts of the body. Those are sound waves that are penetrating the body and bouncing back, and our computers create a picture from that. The MRI, the unit that you're in during this procedure, helps guide and find out which fibroids we can treat. There is a limitation for size, so if your fibroid is larger than the 3 to 4 centimeters, that's the limit of the ultrasound guided or ultrasound, high intensity ultrasound beam treatment, then it's not going to work well for you. So the limits are number. We can't treat all of them. We can treat some, and we can't treat large ones. But the benefits are it's non-invasive. You do have sedation during that procedure, which is medication to keep you comfortable. You're sedated and you're relaxed, and there's a pain treatment as well. Because the sound waves that we have to generate, it's not the same ones that looked at your baby. These are very high intensity sound waves. And what they do is they help to destroy the fibroids, cause them to scar down and get smaller afterwards. There are the MRI, and we'll be able to show you the pictures of your MRI if you go ahead with a consult, or if you've already had one for other reasons. There are some recommended limitations for overall size of the uterus. Some women have come in, and we judge the uterus size with the fibroids by the same meter or measurements that we would judge you on along with a pregnancy. So a 20-week pregnancy is where your uterus comes up to your belly button.
Doctor told me that yesterday.
And above that, obviously you go above 20, you may have a 30-week uterus. When you get to be that large, it limits the success. Not as much for the bleeding, but for the mass symptoms. Our best possible scenario after this procedure is for each fibroid to decrease in size by 50%. So by half. Now you can imagine if your uterus comes well above your belly button, it's very large. Normal uterus should be about the size of your fist. And if that's down in your pelvis, that's far below your belly button. So to be up to your belly button is halfway through a pregnancy, and it's fairly large. We have treated these, and sometimes we do a combined procedure where the OBGYN will be planning to do a hysterectomy, and the patient does want one and may have medical need for one. But they've come to us because they know we can make it smaller and make the surgery easier and safer. Occasionally, we'll do our procedure, and several months later, the patient's not complaining of the same problems anymore and doesn't go ahead with their hysterectomy. It's an abnormal growth in the uterus. There is a genetic predisposition, meaning it runs in families. There is a difference between Caucasian and African American women. It's not fair, but African American women are well above 50% in having fibroids that are symptomatic. Now, below the age of 30, it's not common to have symptoms because it does take years for these to start to grow and then grow large enough, if they're going to grow large enough to cause problems.